Deputy Director General of HIV-Aids Treatment in the Department of Health, Ramphelane Morewane, joins us now for more. A very good afternoon to you. Thank you very much, Mr. Morewane, for talking to us this afternoon. Take us just one step back, if you will. Let's get to what have we done, what did we do right over the years, that which has earned us, praises from everyone across the board?
No, thank you very much, Buyo, and good afternoon to you and the viewers at home. I think as the minister stated in the inset that when the campaign started in 2010, it was really a campaign of going all out to mobilize and motivate and educate and advise and agitate people to test so that people can know their status. Because at the time, it wasn't clear how you are then going to put many people on treatment unless you knew what was the size of the problem. So solving any other problem first begins with understanding the magnitude of the problem. Then you know how much arsenals, how much tools, how much resources you would require. So it started there. And then the country then had to put many people on treatment. We allowed it indeed as a country with the biggest ART program in the world. We have got people that are on treatment for over 5.6 million. In fact, that number is increasing as we're mobilizing everybody else. Now, out of 7.8 million people that are HIV positive, we have been able to put over 5.5 million of them on ARTs. But you see, Voyo and the listeners and the viewers, our actual standard is that men are not coming on board. Now, the numbers we would want to mobilize to come to treatment, 1.1 million people that must be linked to care. Over 650,000 of them are male. And we are therefore saying, in line with the Men's Parliament and the declaration of better men for tomorrow, we would want to mobilize men to come up for treatment.
Do we know why they are not coming forward?
Look, there are varied reasons that you get, such as one, African men don't want to be seen by female nurses. And of course, an answer for many of them, the same African men are allowing the male gynecologists to examine their wives. They do that. No one has ever said that my wife can be examined by another man. Number two, they'll say, no, they don't want to stay in the queues are too long. I know in areas, some areas queues can be too long, particularly because people demand services. But I'm saying the length of stay in the queue can never be equated to the worth of your life. So people are giving many reasons, but I'm saying it's not all doom and gloom, because 79% of people that are on treatment, we still have men in that number. So therefore, those of us that know our status, those of us that are on treatment must go out and motivate for other men to come through. And I can tell you, once we do that, we will be able to put HIV-Aids under control. We may not be able to eradicate it, but we'll be able to eliminate it as a public health threat in our lifetime.
Assuming they were to come forward, to what extent is this program of bringing this additional 1.1 million people to ensuring that they are on treatment by the end of December this year, to what extent is this program, or could this program be affected by that decision by the US President Donald Trump to cut aid to South Africa?
Look, in terms of mobilizing people, there could be, but we want to give an assurance to South Africans that over 250,000 staff workers, staff members that are working in the HIV-Aids response are South African, paid by South African money. Only 15,000 of them are paid by PEPFAR money. So that's a smaller proportion. It's about 4.8%. But of course, some of them we're doing a lot of work, like lay counseling and stuff. So one can say there can be a little impact, but it can be massive because our staff, though they are not many, but I think they are there to be able to pull the line, push the lines, and I'm convinced that it will happen. Secondly, South Africa has never received any funding from PEPFAR, from American government, to buy ARVs. We haven't. We're paying 90% of the total cost of the ARVs from South African domestic funding. 10% is augmented by the money from what is called Global Fund, which is an entity of government of the world. And therefore, to that extent, I don't see any way that the withdrawal could adversely affect, but I can't say there wouldn't be a small dent. And lastly, I want to say to South Africans, Americans are managing their own affairs. Let's manage our own affairs also, and use the few resources that we're having to demonstrate our ability to respond to the scourge of HIV and AIDS.
To what extent also would this campaign depend on the attitudes of staff in hospitals, clinics, and other public facilities? And I'm asking this because quarter in and quarter out, you have your TACs issuing reports where there's still discrimination, there's still ill treatment of people in certain areas or hospitals and clinics. How much effort are you putting into ensuring that when people do come forward or they are keen on coming forward, they don't experience the kinds of things that we've seen coming out of those reports?
Yeah, I think that's one area that we also need to assure South Africans. In the past 36 months or so, we have established a very strong relationship between ourselves and the Treatment Action Campaign, and between ourselves and the people living with HIV and AIDS. Coordinated under SANAC, but also even directly engaging them. We receive those reports. They invite us when they release the reports. We've encouraged that every layer of the health system must interact with those reports and be able to respond straight away. We've got internal mechanisms to also deal with the staff attitude and many other problems that we know have been mentioned. So we are working together with them to address them. But here is what we're doing. For those that may be affected by the attitude, the country has adopted a strategy. It's called the Decentralized Models of Care, or DMOC. Through the DMOC, we are able to enroll patients that are stable, on-reality, stable, and that are showing good progress on what we call multi-month dispensing. So what we're doing, we started by taking them on 2-month multi-month dispensing. We took them through to 3 multi-month dispensing. Now we've been exploring quite aggressively in line with the decision of the pronouncement by the Deputy President to take those that are stable, fit, clinically sound, with the concurrence of the clinicians, to 6-month multi-month dispensing. Why do I say this? That will then shorten their engagement and direct engagement with the clinic staff. If they feel clinic A, the attitude is not that good. But secondly, where they pick up this treatment, it's not in the clinics in the main. There are those that still pick up from the clinics, but majority of them pick them up from pickup points that they would have picked up and chosen and selected as very convenient areas where they can get their treatment. So if we say, me and you, we go to clinic, Masbambisane clinic next door, and that clinic has got a nurse that has got an attitude, I may then have just an opportunity of meeting that nurse once every 3 months. Or if we go to 6 months, once every 6 months. So we are aware of those and we work tirelessly. Lastly, and not the least, we've got 2 systems of quality assurance. One, an internal mechanism called the Ideal Clinic Realization and Maintenance Program, which ensures that nurses and everybody else are able to adhere to a high standard of work. But if, for an example, we are wrong, the Office of Health Standard Compliance is also able to assist us by assessing those clinics and where we're not doing very well to alert us. Through these mechanisms, we've got what we call patient's experience of care. We measure it and therefore patients are able to express how satisfied or dissatisfied they are with regard to a clinic, and then our team is able to respond to address those areas of weaknesses.
Just as a last point, I mean, it's not only testing for HIV is not only low or lower among men, but also this is prevalent within lower people who are living in rural areas, for example, but also people who belong to sort of lower socioeconomic backgrounds.
Yeah, our analysis has brought us to what you call 3 major subpopulations across the country. It's men, it's youth, and children that we need to focus on. When we have time, we may have to talk more about this. Rural areas are not hardest hit in terms of testing and in terms of response. We did an analysis. We lifted out 100 facilities because we wanted to see which are these facilities that are pulling us down. We pulled at 100 facilities. And you'll be shocked to know where majority of these facilities that are carrying a lot of weight are. They are not in Umtata, they are not in Kanduli, they are not in Mafike. They are in the 4 metropolitan municipalities. We found them in the city of eThekwini, city of Johannesburg, the city of Ekurhuleni, and the city of Cape Town. So this is where we found them. And complexities there are purely because these are labor demand centers of high demand, labor demand. Everybody wants to flock there. These are areas with informal settlements in the main, where people are flocking there. These are metros with communities that are highly mobile, because some of them may not even have street addresses. In rural areas, you hardly have these major problems. But I'm not saying it's not there, but I'm saying we're trying to deal with them. Lastly, we also want to focus on prevention to make sure that of the 50 million South Africans that are negative, they must never be positive. So what are we doing? We've got what we call key populations. We're focusing our attention on the key populations, which are people that are exposed, and therefore would want to work with them, work with SANAC, South African National AIDS Council, to ensure that we protect them as far as we can.
Ramphelane Morewane, let me thank you very much for your time. The Department of Health wants an additional 1.1 million people living with HIV to be on treatment by the end of December this year. But it is also encouraging people, especially men, to please come forward and be tested. It's the only way we can eliminate HIV as a public health threat by the year 2030.